likely cause for this is going to be an endobronchial carcinoma. And while you're describing it, you should always look at the rest of the film, looking for bone destruction or contralateral, a straightforward left upper leg collapse due to an endobronchial tumor, possibly with a hilar mass lesion. Although the detection of hilar mass lesion is somewhat fraught with difficulty when you've got so much collapse. So it doesn't always hold that there's a mass lesion. Okay, this is a middle-aged female with abdominal pain. Omental caking, yeah, that's right. Oops, sorry. I've just lost my second screen. There you go. Yeah, so we've got omental caking here, and there's some calcification in the omental caking, small amount of ascites, possible hydronephrosis of that left kidney, more omental caking with icing. Actually, there's hydronephrosis of the right kidney, and we've got a pelvic mass lesion with calcification. So this is a papillary carcinoma of the ovary with mesenteric and peritoneal metastatic change. Okay, trauma. Posterior dislocation. So what we've got here is we've got a situation where the glenoid and the humeral head are superimposed, and there should be a bit of a gap, and it should be parallel. So the gap at the top should be the same as the gap at the bottom, but these are clearly overlapping. We've got the trough sign, which is this white line here, and it indicates that there's been a reverse Bankart lesion and a reverse Hill-Sachs lesion and a posterior Bankart lesion. So this is a posterior dislocation. There you go. So if you wanted to do the scapular Y projection, this is going posterior. There's the glenoid rim, and this articular surface is now posterior. Okay, this is a most unusual condition. You may never have seen it before. What do you think this is? Yeah, very good. SK has got it right. It's called fibrodysplasia ossificans progressiva. And you get sheets of calcification and ossification, which eventually lead to non-expansion of the chest. Okay, so if they bind the ribs together, there'll be no expansion. And here is similar change seen on the abdominal film. Fibrodysplasia ossificans progressiva. Patient is an alcoholic, weight loss, cough. What's the most likely diagnosis? Yeah, TB. We've got very irregular consolidation, possibly with cavitation. There's volume loss in that right upper lobe. There's the oblique fissure. And this is tuberculosis. Absolutely classical example of a pathology. What's the pathology? Yeah, rounded atelectasis. So we've got the comet tail here, here, and here. And we've got pleural thickening, pleural calcification, and volume loss. So rounded atelectasis. If you were to give contrast, this would enhance to a higher degree than you would expect a tumour to enhance. So that's one of the ways of working it out. Okay, what have we got here? Sorry, it took a bit longer to load this. This patient presents with chest pain. Yeah, they've got a pulmonary embolus, and in the posterior right lower lobe, there is a pulmonary infarct. So here is the pulmonary embolus in the right lower lobe pulmonary artery, and then we've got pulmonary infarct here. So these patients not only will have all the signs and symptoms of a pulmonary embolism, but they will also have hemoptysis by virtue of the fact the patient's got a pulmonary infarct. Just here. The other important thing to note when you look at ratio, right ventricular to left ventricular ratio, and it is slightly more than one. So there's a little bit of right-sided heart strain there. So there's the pulmonary embolus. There's the thrombus, the thrombus in the right lower lobe pulmonary artery. There's the pulmonary infarct in the right lower lobe pulmonary artery. And the pulmonary infarct classically consists of consolidation with a ground glass halo. And the ground glass halo is, of course, due to hemorrhage. Okay, what have we got here? Chest X-ray, relatively normal. Yeah, there's a mediastinal mass which is well defined above the clavicles. So it's either in the posterior or middle mediastinal mass region. This is an apical view. So the lesion is here. They're the breast shadows, but the lesion is well defined above the clavicle. Sorry, above below the clavicle, but obviously above the clavicle on the ordinary view. So if I just go back, it's above the clavicle here. But when we do the lordotic projection of the apical region, it's now projected below the clavicle, but it's well defined. And CT demonstrates that this is a posterior mediastinal mass lesion whose epicenter is in the same vicinity as the intervertebral foramen. So this is a neurogenic mass. Yeah. So this is an apical view, as I call it. You might call it a superior mediastinal view, but I know this to be an apical view. Okay, what's the diagnosis here? Signed above the clavicle on the PA film. Yeah, this is gout. So we've got soft tissue swelling, which is dense, and then we've got an erosion in the juxta-articular position. Okay, this is a really difficult film. It's a patient who is having respiratory failure. And if you look very carefully, you can see that there is ankylosis of the costotransverse joints. Ankylosis of the costotransverse joints. And they've got ankylosis of the facet joints. This is a patient with ankylosing spondylitis. Sometimes they may get upper zone fibrosis, or they may just get a restrictive defect because they can't expand the chest any more than what you see here, because all the joints are now fused. Okay, we've got a tumour here and what looks like a tumour there and a tumour there. Carotid body tumours, yeah, paragangliomas, and these are multiple, bilateral, and usually it's at the bifurcation of the common carotid artery into the external and the internal carotid artery. So this is where you tend to get the carotid body tumours. They tend to be within the carotid sheath around this sort of area here. Okay, and that's exactly what you're seeing here and here, and this one just happens to be a bit further up. They do get the salt and pepper appearance, whether they are in the region of the jugular foramen or whether they are around the carotid. The salt and pepper appearance is it's mainly seen on MRI, where the signal void is due to arterial blood flowing through the enhancing carotid body tumour. So I think this is another movie. So let's have a little look. So here's the carotid body tumour around the bifurcation. This one's a bit higher around the external carotid, but the main ones are around the bifurcation. Okay, and this is another one. This is gadolinium enhancement. So can you see that this looks like a pepper pot appearance? Because the arteries that run through that carotid body tumour are causing a signal void because of the fast flowing blood. And then we've got two carotid body tumours here at the bifurcation, which are obviously in the carotid sheath because of the bifurcation of the carotid artery. But the salt and pepper appearance is much more florid in the upper one as opposed to the lower ones. Okay, this patient has fallen on a trampoline. Any thoughts? Yeah, so we've got a fracture of C2 just there. So fracture of C2 just there. So there's a slight increase in soft tissue. Not much, but slight, but there's the fracture just there. And you can actually see that the anterior longitudinal line is relatively okay, but there's a step when we go up the posterior longitudinal line. So there's a step just there. And so there's a fracture posteriorly, fracture anteriorly along that facet line. There you go, I've drawn it, and there's the soft tissue swelling. Somebody said, what about C7? Well, I think there's an old injury of 2, 3, 4, 5, 6, C6 and C7, but they look old. Clay-Shivler's fractures, well spotted. Okay, this patient has had a CTPA for chest pain. For some reason, I have to go through this process every time I play a movie. If anyone can suggest to me how I can avoid that, I'd be very grateful to hear from you. So every time I play a movie, I have to grant access from a file I've got on my computer. Yeah, so this is an intramural hematoma. It's a Stanford type A, and it's extending from the ascending aorta right down to the aorta in the upper abdomen. You can see it's involving the aortic root with a hemopericardium. And we've got SVC obstruction because of the hemopericardium and the ascending aortic dilatation. And there's the intramural hematoma with medial displacement of the intima. Now, somebody says, how do you differentiate it from dissection? Well, actually, it kind of doesn't matter because they are both treated in the same way. An intramural hematoma and a dissection do require the patient to have surgery. Okay, what have we got here? Yeah, got an anterior mediastinal mass. Can't see the right heart border. We can see blood vessels running either in front of it or behind it. That's not that helpful, that low down. But we've lost the right hemidiaphragm anteriorly, probably, because this is obviously an anterior mediastinal mass. And when it's involving the cardiophrenic angle, you need to think about lymphoma, pericardial cyst, pericardial fat pad, and a Morgani hernia. I can't see any bowel gas. It doesn't look that dense, so it could be a fat pad. The patient's not particularly obese, but it could still be a pericardial cyst. Do a CT scan, and it's a pericardial cyst. So the Hounsfield number is -2, which is effectively 0, and this is a pericardial cyst. So-called a spring water cyst, because the contents of the cyst appear like water from a spring. Young patient with lymphadenopathy and a monitoring device for arrhythmias. Not lymphoma. Why would somebody have, yeah, sarcoid. Yeah, patient's got cardiac sarcoid. and they've got lymphadenopathy in the mediastinum. Okay, patient with ARDS, they've got a deep sulcus sign. Okay, compared to this side here, but you can see the lung edge anyway, so there is definitely a pneumothorax. There's a chest drain draining that pneumothorax. We've got ARDS, so the lungs are stiff. There's an ET tube in situ. There's a nasogastric tube in situ. There's a right internal jugular line in situ. And then there's another tube in situ. And I'm going to draw it blue. And this one here ends about there. What is it? What is that left internal jugular tube? Yeah, it's the left. It's going in the left SVC. So the patient's got a pneumothorax, ARDS, and a left-sided SVC. Okay, skiing injury. Osteochondral fracture. Can you see? Oops. Can you see a fracture just there? Yeah, that's a fracture at Gerdy's tubercle. So this represents a second fracture. And you've really got to worry about an ACL rupture in this particular patient. Okay, so second fracture with an ACL rupture. There's probably a suprapatellar effusion, although the patient is well nourished, and so it can sometimes be very difficult. And this was the patient. So they've got an ACL rupture just there with this effusion, which is sometimes difficult to pick up. And the key is to look at the avulsion fracture at Gerdy's tubercle. Okay, what have we got here? Patient had had a lumbar puncture 2 days earlier and now develops loss of sensation in the bladder and bowel. Could be an epidural hematoma. Anything else it could be? Could be arachnoiditis, possibly. What about an abscess? An epidural abscess? The only way you're going to find out is to give gadolinium and see if that lights up. And there it is. So we've got a ring enhancement, T1 with gadolinium. There's the cord or the cord requiner. This is the CSF in brown, and whatever is in the epidural space, whether that be disc anteriorly, or whether that's a meningioma or a schwannoma or an abscess, it's going to push the thecal sac inwards like this. Okay, and the contents of the thecal sac, whether that be cord or cord requiner, get clobbered. And that was an epidural abscess. How do you tell from subdural? Well, or do you mean intradural? So it's the angle. So an extradural, there's the thecal sac. An extradural lesion will compress the thecal sac like that. Gets squashed. Okay. So there's the cord there. So that's extradural or epidural. If it's intradural, you'll get the cord, and then you've got a lesion inside. Okay, so it shouldn't really cause the fecal sac to take on the shape like that. It should be circular. Okay. The more I practice, the luckier I get. Thank you to Radhika Prasad for this one. What's the diagnosis here, guys? AVN of both hips or just one? It's actually both, isn't it? So we've got AVN just there, AVN just there, and you just see it there. And then we've got a transplant kidney in the left iliac fossa. So it's likely that steroids have been implicated in the development of AVN. Okay, this patient has got back pain. Yeah, bilateral sacroiliitis. Don't forget the SI joint has, let me just get rid of those marks. So SI joints, synovial inferior. Therefore, the inferior part of the joint is the first one to become eroded. Okay, so this is sacroiliitis. And if you get unilateral sacroiliitis, it's almost always due to infection. Okay, and you can just see it there on the top of the film. Sorry, top of the SI joints on this film. Diagnosis. So what should happen is the bile duct should get tapered as you go out towards the periphery. But this is getting tighter, then bigger, tighter, then bigger. And it's like a beaded appearance. Yeah, it's sclerosing cholangitis. Okay, this patient is intermittently breathless. Chest X-ray, AP erect. We've got 1, 2, 3, 4 ribs crossing the midclavicular line and the diaphragm. Therefore, you can't really say that that's ground glass change because it could all be due to the poor inspiratory effort. But actually, there was ground glass change on that X-ray. We went along and had a CT, and it shows lots of little nodules which have coalesced to form these central lobular nodules with areas of air trapping, and this is hypersensitivity pneumonitis. This next patient was involved in a stabbing, and this is about a month later, they come back. What's the diagnosis? Yeah, pseudoaneurysm of the common carotid artery. Yeah, pseudoaneurysm of the common carotid artery. And the pseudoaneurysm is due to trauma with a knife blade. Diagnosis? Fibrous dysplasia. Yeah, absolutely right. So we've got this ground glass change, we've got these unusual ribs, and this is fibrous dysplasia. Okay, what have we got here? It could be that, but um, so you think there might be some cystic change in the right upper lobe. Let me just, yeah, it looks a bit like that. But look at the first rib, look at the third rib, and you can see that there's an expansion of that second rib anteriorly. Okay. If you do an oblique view, you can see that this is fibrous dysplasia of the second rib. Okay. Fibrous dysplasia of the second rib. Okay, how would you describe that lesion in the frontal lobe? Meningioma, pot puffy tumor, possibly, but this is actually a meningioma, and it's an intraosseous meningioma. Okay. You can see the dural tail, so if I'm drawing this properly, you've got the dural tail, there's the meningioma, and it's on both sides of the bone, so therefore it's an intraosseous meningioma. Okay, small bowel meal for somebody who is suffering from malabsorption. Not scleroderma. Jejunal diverticulosis. Okay. Jejunal diverticulosis. So they get overgrowth of overgrowth of bacteria, which causes a reduction in vitamin B12. Okay, due to this bacterial overgrowth within the jejunal diverticula. Just another example of the same, jejunal diverticulosis leading to B12 deficiency. Okay, what have we got here? Gastric mucosa on a barium meal. Got target lesions, okay? So in other words, a central dot and a lucency around that dot. There's one, there's another, there's another. So called bullseye or target lesions. And you think about the following: melanoma metastases, lymphoma, Kaposi sarcoma, carcinoid, and a solitary, if it's solitary, lipoma. Okay, lipomas tend to be solitary, not multiple, but these are multiple. So you think about melanoma, mets, lymphoma, Kaposi sarcoma, carcinoid. Why not ulcers? Yeah, gastric erosions might look like this, but we very rarely see those these days. Pancreatic rest is another one, but I think that's usually solitary, if I'm not mistaken. Bullseye lesions in gastric lymphoma, 1976. So long time ago in the American Journal of Röntgenology. Okay, what have we got here? Patient's got a limp. It's not fibrous dysplasia. So we've got SUFE, which is burnt out, and we've got a renal transplant, which has now rejected and calcified. So it's old bilateral SUFE and rejected renal transplant. Okay, what is the cause of this patient's abdominal distension? Ascites, well done. There's the ascending and descending colons. There it is, ascending, descending colon. And all of this out here is ascites. Okay, what have we got here? We've got a pacing wire. Okay, and that pacing wire may well be going into the coronary sinus. Okay, and we've got this calcified lesion involving the left atrium, and this is a porcelain left atrium. Porcelain left atrium. And all that means is the patient is likely to have had rheumatic fever. So there it is. There's the calcification in the rim of the left atrium. Classical diagnosis, what is it? Not TB? Sarcoid. Yeah, sarcoid. Absolutely characteristic. Bronchovascular beading, subpleural nodulation, bronchovascular beading, subpleural nodulation, and there's no mistaking that for sarcoid. Okay, this patient has had contrast, no contrast. You know it's got contrast in because the superior occipital sinus. There's some rim enhancement, but it's not that. It's not that convincing, really. Patient, they don't know whether you don't know whether the patient has got an abscess or metastases. The history is a bit vague. Do they have a temperature? No real way of knowing. So the patient has T2 weighted MR, just shows lots of vasogenic edema. T1 with gadolinium looks a lot more positive than the enhancement seen on CT. So we know there's a definite lesion there with edema. And then it shows a restricted diffusion on DWI, which is mapped to the ADC by an inverted signal. So this is an abscess, yeah. So it's an abscess rather than a neoplasm. So it's a great way of picking up a cerebral abscess. So if anyone ever asks you, what would you do for a cerebral abscess? Well, always go clinically. And if the patient's got a fever, they really need to start antibiotics. Clearly, the neurosurgeons need to get involved at an early stage. But you can do an MRI scan and do this DWI, and you get this restricted diffusion. Recurrent chest infections. Yeah, got a fluid level and a very dilated esophagus, which is giving a double right heart border. So this is achalasia. Okay, and you'll notice that there's no aspiration. Somebody's asked for the diagnosis of the last case. It was a cerebral abscess. Cerebral abscess. There's the lateral of that achalasia, very dilated esophagus with fluid in, and it's pushing the trachea anteriorly. Okay, so this is another patient, sorry, the same patient, I beg your pardon, who has got a fluid level further down, and they're passing a nasogastric tube, and there's the nasogastric tube that's been coiled up in the high in the esophagus. Okay, I think this is a movie, so let's show you the movie. Does anyone know how to stop all of this? I have to do it every time I play a movie. If anyone knows, I'd be grateful if you let me know. Okay, so we've got bronchiectasis, bronchoceles, gas-filled bronchi, bronchoceles which are full of fluid, and this is a patient with allergic bronchopulmonary aspergillosis, or ABPA. Okay, diagnosis, abdo pain, Wriggler's sign, yeah. So we've got both sides of, oops. You see both sides of the bowel wall. You can see both sides of the bowel wall here. And this is the football sign, goes all the way around. And it's shaped like an American football, not a soccer football. Okay, so it's not that one, it's that one. Therefore, it's an American football. Just means pneumoperitoneum. This patient has got a chest drain in situ on the right, one in the axillary space, one in the mid-clavicular line. There's a tracheostomy tube in situ, nasogastric tube in situ, intercostal tube, again left side. Got lots of surgical emphysema. We've probably got streaky shadowing up here as well, but it's the continuous diaphragm sign that tells you that this patient has definitely got pneumomediastinum. Okay, what have we got here? Yeah, so we've got hypertransradiancy of the left mid and upper zone. And so the first thing you do when you see a hypertransradiant lung field is that you count the number of vessels, and they are reduced on that side compared to this side. Okay, therefore it's a lung problem on the left-hand side. And that lung problem could be Swyer-James syndrome. It could be a very large pulmonary embolism, unlikely, but it could be. And it could be a carcinoid tumor obstructing that bronchus. But this was a patient with Swyer-James syndrome. And you'd expect on exhalation for this to stay the same size or get bigger, and then this would get smaller, okay? So you get contraction and volume on the right and no contraction on the left. The hilum has been pulled in, not because it's been pulled in by anything. It's just that it's failed to grow. So there's a hypoplastic pulmonary artery. And the CT shows very nicely that we've got mediastinal shift. We've got a paucity of blood vessels compared to the other side. And this was a Swyer-James syndrome. You almost always get bronchiectasis with Swyer-James syndrome or McLeod syndrome. So Swyer-James and McLeod's are synonymous, okay? Right, this is a young lady with weight loss. Is mediastinal shift an urgent indication? No, not really. No. So what's wrong with this chest X-ray and this young lady who's got weight loss? Medial humerus lesion, no. There's an abdominal calcification here. Okay. And so the patient needs an abdominal film, and this patient has got a retroperitoneal liposarcoma, okay, which has subsequently calcified. Okay, retroperitoneal sarcoma. You've seen it before, ovarian mass lesion with calcification, lots of deposits. So not really a mental cake, but lots of multiple cakelets. That's not the right term, by the way. That's just what I've just said. They've got areas of calcification along the peritoneum, small amount of ascites, and this is papillary carcinoma of the ovary. So this patient's got hypertransurgency, and if you look at the number of vessels, they are equal on both sides. Therefore, it must be a chest wall problem, and the clavicle is that wide on the left and that wide on the right. So there's a small clavicle, certainly in terms of cross-sectional area. We've got loss of soft tissue here compared to over here. Therefore, it's polio on the left-hand side. Could it be Poland syndrome? Probably not, actually, because it's involving more than just the pectoral muscles. Okay, how old is that patient? When you superior iliac, sorry, the iliac crust apophyses, they must be between 18 and 25. And therefore, this is a patient who's late adolescence and they've had a sports injury. Got an adductor avulsion. Yeah, adductor avulsion. Yeah. Yeah, we've got a meningioma, got calcification within the meningioma, and we've got hyperostosis of the adjacent bone. So sphenoid wing meningioma with hyperostosis. Okay, what is going on here? Somebody's asking what was the diagnosis of the patient with the smaller clavicle? It's polio. So all the muscles of the chest wall on the left were diminished, not just the pectoralis muscle. Yeah, scleroderma, acroosteolysis, scleroderma, most likely. Trauma, posterior dislocation, yeah. And again, that measurement there is less than that measurement there. Now, when you get the internal rotation of the humeral head, although that is seen with dislocation in a posterior direction, it can also be seen in patients who internally rotate their humerus, okay? So it's important just to remember that. But the sign I'm looking for is the loss of parallelism. So normally the humeral head should be parallel. I haven't drawn that very well, but that should be parallel to that line there. And the fact that it isn't means that there's a posterior dislocation. Yeah, there's a grade 1 subluxation of the AC joint, well spotted. And there is the reverse Hill-Sachs lesion. So, and if you look then at this end on, you can sometimes see the trough sign, which is lots of bone, which is impacted. That's called the trough sign. Lymphadenopathy and lumpy bumpy meningeal enhancement. sarcoid. Yeah, well done. Sarcoid. And this is sarcoid. Could that be TB? Yes, it could. But in the context in which we're dealing with, this is most likely to be sarcoid. And both sarcoid and TB tend to involve the basal cisterns, where you get this very nodular enhancement of the meninges. Premature neonate. Is it a PE or a lymph node on the right? You can't really differentiate. Yeah, necrotizing enterocolitis. There's the falciform ligament. There's the football sign just here. There's the falciform ligament just there. Okay. Necrotizing enterocolitis with pneumoperitoneum. Diagnosis. Monteggia fracture. So we've got a fracture of the ulna with a dislocation of the radial head, which has gone anteriorly. Diagnosis here. Left lower lobe collapse. Yeah. So dual chamber pacemaker. You can see the collapsed left lower lobe here. And fairly classical. And then we've got hypertransuradiency of the expanded left upper lobe. Okay, diagnosis here. Both sides of the bowel wall are seen. Wriggler's sign. Yeah. Okay, this patient comes in with a coma. Any thoughts? Yeah. Basilar artery tip thrombosis on the axial. But if you look at the sagittal reconstruction, it's more than the tip. It's involving almost all of the entire basilar artery. And we've got posterior circulation infarction. Patients bad. Well, if you have an infarct in the posterior circulation, the pressure inside builds up and they get squeezing of brain together, and the aqueduct of Sylvius just shuts up. So they get hydrocephalus. Does the hydrocephalus need to be drained? Well, the problem is if you've got such an extensive stroke, usually there's no treatment. Why do they have infarcts? Well, they've got an occlusion of the basilar artery, and this extends into the posterior circulation. Big frontal sinus and pre and post gadolinium. Acromegaly, yeah, well done. There's the aortic knuckle, meaning that this lesion is not in the middle mediastinum. It fades as it goes above the clavicle. It fades as it goes above the clavicle. Therefore, it's an anterior mediastinal mass. And let me show you the contiguous with some middle mediastinal lymph nodes, bilateral small pleural effusions. This was lymphoma because it's all contiguous. So if it goes above you found that useful. Thank you for your attention. Here's some nice music.